So when we're looking at like red flags and clues, are there other types of clues that get seen? Like, are you seeing things getting missed when you're imaging in supine, like things related to vascular compression, functional stenosis, Chiari? Like, how does
Uh,
that play in with supine imaging?
they are getting missed. This is my personal opinion about the upright versus recumbent is that there are only a few samples, and this is I've been tracking this for probably the last 8 to 10 years. That if you go onto Google and you just type in recumbent versus upright MRI, there's only a few samples of the massive difference between an upright and a recumbent Chiari that pop up. And that's not to say that there aren't a lot more out there that are being seen, but just not being uploaded onto Google and being found as images. But my personal experience that I've had with patients who have had recumbent MRIs and then go end up getting an upright MRI, as far as how far or how much of a difference their Chiari, or if they're going to call it that, generally it's not 5 millimeters, they don't even call it that, but their low-lying cerebellar tonsils
Mhm.
go further low-lying in the upright position. I personally clinically haven't seen that as dramatically as has been, propagated out there in the conversations. And so I don't think there's a massive limitation in just doing recumbent imaging, but then doing it stressed. So where you're trying to put ligaments to their end load or their end
Mhm.
point load, where you may see, fibers that are frayed and light spaces or fluid spaces around them, as opposed to doing it in neutral where the ligaments are all buckled and you might not get a true idea of their damage until you actually put them under a stretch load. That's my,
So the
would
position would be the stretch load. So like MRI
correct.
under, okay.
So an MRI done with a patient's head fully rotated, and then they do the slicing with their head maintained in rotation, because they
Uh,
do sometimes MRIs with patients with NCTs with flexion, and then they'll do the slicing and extension.
yeah,
But they have to get into doing rotation and side tilting while they're doing the MRI slicing, because it
yeah.
is possible. I mean, I've seen scans from patients from Germany, from um, Guatemala, and different South American countries where they're doing this not routinely but quite often,
Mhm.
and it is fascinating how much cool stuff you can see on those positional MRIs. And we've been trying to, convince the local MRI facilities in BC to do just rotational positioning, and they're claiming that their machines don't have the ability to do that, but they do.
Yeah.
Unfortunately, I think the issue is that they don't have radiologists that are willing to sign off on the reports when they're doing non-routine MRIs, and so they need to start learning a little bit more about what they could possibly see with the rotation MRI and start educating themselves so they can actually feel comfortable reporting on these things,
Mhm.
because it will yield a lot more information for patients as we start getting more radiologists that are training themselves in this and comfortable reading these MRIs, because people can always go on to different platforms and get a second opinion from a neuroradiologist from Britain or somewhere else that has been trained in this and has been practicing this, so that even if the local guys are not willing to comment on it because they feel the liability is too high, they can at least say it was done, and the patient's going to go get a second opinion read from somebody who knows what they're looking for.
So is it like a liability thing because there's not a standard criteria? So like
Well,
you
there is.
flag
It's
normal.
there is. It's just not being practiced.
Oh, interesting. And is in
Because
that,
like,
does Canada have that?
what do you mean?
A standard criteria for if someone was able to do a MRI imaging in rotation, left, right,
Hmm.
would a radiologist be able to sign off and flag? Like, do they have that criteria to
Well, the
note?
criteria exists. Whether it's being recognized in Canada, I
Oh, I
don't think
see.
so, because it's not
Yeah,
being practiced. But
gotcha.
there is a criteria out there. There are different venues where people can learn, as radiologists can learn about what to look for in different positions, because it is being reported on, it is being conducted around the world, just
Gotcha.
not yet collaboratively, globally. So it's at some point in time, it's going to have to be, because functional imaging for the musculoskeletal or musculoskeletal system, so skull, spine, and appendages, is
Mhm.
going to have to be more and more conducted in dynamic stress types of situations versus neutral anatomic, like you
Yeah.
mentioned earlier, because you miss a lot when you're just looking at neutral anatomic versus stressing somebody. If somebody says, when I bend my knee this way it hurts over here, ultimately the logical thing would be to have them recreate that under imaging
Mhm.
situations, and then see what you see at the place where they point to. And if you don't see anything, then it's likely a soft tissue. If you see something bony occurring that's weird, then you can sort of deductive reasoning can help you figure out what it might be, so that somebody who's going to do something procedurally or therapeutically with it will have a better idea of what the specific problem is, so that they can address it without having to guess.
Yeah. And are there other like, so I hear from patients like around the world essentially who are like just desperate to find out like, is this something I should keep pursuing? They keep telling me nothing's wrong. So when we're talking about like red flags or clues, um, do you see like in your patient base like people who are having more like vascular inflammation and like those types of symptoms, so RCVS, vasculitis, like are those patients tending to also come in with those types of um, little bits of clues in their imaging as well?
Yes, yes, there's a
Okay.
lot of overlap. And so
Yeah.
people from around the world, they, like you said, they do get that, there's nothing wrong with you kind of thing, or we can't figure it out kind of thing.
Yeah.
And oftentimes there are clues. And so those are the types of patients that will then contact me and or my assistant, and they'll send us the imaging, and I'll have a look at it and look for these clues, and then relay that to them in an
Okay.
explanatory video. So a Zoom call like this, and then hopefully guide them along the path of being able to bring that information to somebody wherever they are locally, their doctor, like I said, Sweden or Guatemala or wherever they are, and have a discussion at least, and start that conversation going. Because like you said, everywhere, doesn't matter where you are, this is definitely falling on deaf ears,
Mhm.
to the physicians for most patients.
Yeah. And people are just thinking like, okay, it says I'm normal, therefore we don't continue to investigate, despite the fact that I'm having progressive symptoms that are,
Yeah,
getting more and more life limiting, but also kind of
yeah.
starting to become
So
risky,
they
I guess.
benefit drastically from having their hand held, for example, by someone like myself,
Yeah.
who can, knows both sides of the spectrum, and knows what the doctors need to hear, and I can, formulate
Yeah.
verbiage for what they would bring to their doctor, and help them through that, so that it's not basically falling on deaf ears,